Okay, so here's normal and abnormal. And this is what happens when pigs smoke. Now you might say, well, how's a pig smoke? Well, what they do is they keep these pigs in a confined environment, and then 20 times a day for one pack of cigarettes a day, they change the air in the room, and then they autopsy these pigs. And of course, I bet you can tell this is the normal lungs, these are the abnormal lungs. And that's what happens whenever people smoke. And of course, this is what we're here to talk about today. Here you can see this is the main windpipe here called the trachea. It splits into two parts. One part goes down the left side, one part goes down the right. And of course, there's the large tumor in the top part of the left lung. It's spread to all the lymph nodes down here as well. And it's also spread to some other areas. You can see over here in the right lung, there's some tumor nodules. So this would be obviously a pretty advanced case of lung cancer. So here's what we're going to talk about today. We're going to talk about some of the causes of lung cancer and some of the risks of smoking, signs and symptoms of lung cancer, the diagnosis and treatment as well as the prognosis, and what can we do to prevent it, and what does the future hold. So let's go over some definitions. Lung cancer is an invasive tumor that starts in the major airways or the smaller bronchial tubes or in the lung substance itself. The tumors that start elsewhere and spread to the lungs are not lung cancer. So oftentimes people say, well, you know, my grandmother had bone cancer, but then it turned into lung cancer when it spread to her lungs. That's really not what we're talking about, and the reason is that there's differences in the treatments for those two different conditions. So these are tumors, what I'm going to talk about today are just tumors that start in the lung and have not spread to the lung. And you may hear this word, bronchogenic carcinoma. That's another name for lung cancer, one that sort of fallen out of favor recently, but you'll still see that. And if you hear someone says they have bronchogenic carcinoma, that's the same thing as lung cancer. Well, here's just some basic facts, and they're not very pleasant, but lung cancer is the leading cause of cancer deaths in the United States. And in fact, more people die of lung cancer than die of breast, colon, and prostate cancer combined. And we know that cancer is the leading cause of death in North Carolina, just slightly more common than heart disease, and so therefore lung cancer is a pretty important part of what we take care of as physicians here in North Carolina. Just to show you, this is from 2009, the most recent data that I have, but you can see that lung cancer accounts for more deaths than any other diseases of the heart and cerebrovascular disease, etc. But it's a very common problem that we see. Well, who gets lung cancer? Well, smokers, obviously, we all know that. But there are some things that maybe you haven't thought about before, but secondhand smoke also is a risk factor for lung cancer, and prolonged exposure to secondhand smoke can increase your risk of lung cancer by 20 to 30%. Radon. Anybody know what radon is? Radon's a gas. It's a gas that actually comes up from the rocks underneath your house, underneath your foundation, and it's estimated that it causes 10% of all lung cancers. And nowadays in North Carolina, there's a law that says you cannot buy or sell a house without getting a radon inspection and having your house undergo remediation if you have it. I know because I recently tried to sell my house and had to get a radon inspection done. And they come in and they monitor how much radon's in your house, and then you have to put in fans and exhaust in your foundation to suck that radon out from underneath your house into the environment so that your neighbor can get it. But in any event, radon causes 10% of all lung cancers. I didn't really think about that years ago. Asbestos, we all know that asbestos causes mesothelioma. If you don't believe that, you can just watch any late night TV show and you'll see that. Every commercial is for mesothelioma and asbestos exposure. But it also causes lung cancer. Air pollution causes lung cancer. So does exposure to certain chemicals such as uranium and beryllium. Those are radioactive substances, but things like gasoline and diesel exhaust can also be associated with lung cancer. Arsenic, genetics, if you have a first-degree relative who's had lung cancer, then you're more likely to have lung cancer. And one thing that I think is becoming more and more common is prior radiation to the breast or lungs, and mostly to the breast. When I first started surgery, we never radiated the breast because we just did mastectomies and radical mastectomies. Nowadays, that's almost never done. It's more of a lumpectomy and radiation therapy, and we know how common breast cancer is. And as I look out over the room, I see a lot of women, and I expect someone in here has already been diagnosed with breast cancer. And they may have already received radiation therapy. That's part of their treatment for breast cancer. The problem is that if they smoke while they're receiving radiation therapy, the radiation therapy in conjunction with the effects of cigarette smoking make the development of lung cancer much more likely. So it's not at all uncommon to have a woman come in with the breast cancer on the right, get radiation therapy, and then 5-6 years later present with lung cancer secondary to the radiation effects. Okay, well, what about some of the signs and symptoms? Symptoms, that means what does the patient come in and complain of? Well, they may complain of a cough. Well, who hasn't had a cough in the last month? They might cough up blood. That's called hemoptysis. They might be short of breath or wheeze. They might just say, I'm just not feeling very well. I feel somewhat fatigued. I might have some weight loss, unexplained. I'm not really trying to diet, but I've lost 30 pounds here in the last 3 or 4 months. And what are the signs? That's what the doctor might actually see when he examines the patient. Well, he might see decreased breath sounds. That means when he listens to the lungs that there's no air getting into that segment of the lung. I could remember that very first slide we showed. If you were to listen over the top part of the left lung and there was a big tumor there, you wouldn't hear any lung sounds. So the physician might find that. He might find some wheezing or clubbing of the fingers. Clubbing of the fingers is kind of interesting. That's where your fingernails become rounded. And that happens with lung cancer. Not everyone, but it might. And so, if you ever see someone who's got their fingernails look like a spoon turned over. You stir up your coffee, you put your spoon down. Well, if you lay it down on the side and it's like this, that's how someone's fingernails might look. And if you see that, that's oftentimes a sign of lung cancer. You can see droopy eyelids. What's that from? Well, some of the nerves that actually go up to your eye and control your eyelids actually run right along the lung. So if you have a lung tumor that's involving those nerves, people say, I can't open my eyelid. We had a patient last year came in with that. That was their only complaint. They said, I just can't open my eyelid. What's wrong? I think I have a sty. I don't even know what a sty is, but I had to go look that up. But anyhow, it was actually from lung cancer. And patients might be hoarse. They might be hoarse because of just chronic cigarette smoking, or they might be hoarse because some of the nerves that control the voice box are involved, and they might cause hoarseness as well. So how do you make the diagnosis of lung cancer? Well, most patients now, first thing they'll do is they'll get some sort of a chest x-ray. Almost everybody will have a chest x-ray made, and so it'll be abnormal and there'll be something suspicious about it. It'll show something abnormal on the x-ray, which will then lead to a CT scan of the chest. And that frequently will lead to a PET scan and maybe even an MRI. MRIs, I think we know what they are. And these are all done. These tests, which are basically radiology studies, are done to characterize the lung mass. That is, how big is it? Where is it located? What's the size? Is it completely rounded? Is it sort of oblong in shape and things like that? And it also looks for sites of potential spread. So like, are the lymph nodes involved? Are the lymph glands next to the lung involved? Are there any spots in the liver? Are there spots in the bones? And things like that. So here's the survival by stage. So this is after you've done all those studies and you determine that this is a lung tumor in the lung. If you look at stage 1A, the overall 5-year survival, what does that say, Lauren? 50? 50%. If it's 1B, which again, that's pretty good, that's a good prognostic sign. You can see survival is 43%. That means 4 people out of 10 will be alive after 5 years. And if you look at even the best scenario, where it's a stage 1A, that's a tumor less than 2 centimeters in size and no lymph nodes are involved, only half of those people are alive after 5 years. And so I can tell you, whenever you walk out and talk to a patient's family and you say, okay, Mrs. Jones did great with her surgery, the tumor was 2 centimeters in size and no lymph nodes were involved. And they say, wow, thank you, you got it all. You got it all. And so now she's cured, right? And in the back of your mind, you're thinking, it's a flip of a coin, really. So even in the best circumstances, this is a deadly disease. So what are the treatments? Well, this is the best we can do. So here's the treatments. For stage 1, that is a tumor that's localized to the lung, surgery is the preferred treatment. Other options might include radiation therapy. For stage 2, where the lymph nodes are involved, surgery could be used, but you have to do something that's going to now, once it gets in the lymph system, it's now sort of spread throughout the lung, so now you might want to add chemotherapy to it. If the lymph nodes outside the lung are involved, surgery is no longer an option, because once it's gotten beyond the lung, taking the lung out isn't going to help you any. So in that case, we use radiation and chemotherapy, and then if the tumor is really spread to the bones or to the liver, then we usually just use chemotherapy alone. But again, as I told you, survival rates, you're talking about 2, 3, 4, 5% perhaps for stage 4. Well, the treatment is also determined by the type of lung cancer. And I showed you one of those original slides where it showed adenocarcinoma and squamous cell carcinoma. Those are just the way they appear under the microscope. But the way they appear under the microscope is an important factor to determining how you treat it. And for the most part, we usually treat non-small cell. Now, I know this is going to get kind of confusing, but the words small cell and non-small cell are just the two main classifications of lung cancer, and the reason why they're called that is because under the microscope, one's really tiny little cells, and the other ones are bigger cells. It's really that simple. And then of the bigger cells, then there's different kinds, and so actually one type of non-small cell is actually called large cell. Tell me that's not confusing. So not all non-small cells are large cells, although they appear large cell under the microscope. All right, so what do we do? Surgery, that's what I do. Surgery for localized lung cancer, stages 1 and 2, that is with the tumor confined to the lung or to the lymph glands. And we can do different things. We could take out just a portion of the lung, and I'll show you this in a minute. We can take out a lobe of the lung, that's called a lobectomy, or the entire lung, which is called a pneumonectomy. And for stage 1, I say survival is about 60%. For stage 2, that would be a tumor that involves the lymph nodes. Now you can either remove the lobe or the entire lung. You can't take out just a piece of the lung because you'd leave the lymph nodes behind. So again, that doesn't make any sense. So here's what they look like. So here's a tumor, a little hard to see. Here's again, this is the windpipe with the lymph glands there. And that's the tumor. No lymph nodes are involved, so you can take a wedge out of the lung, and that's called a wedge resection. Here's, again, the lung is divided into these different lobes. There's the tumor. You can take a lobe out. You couldn't do a wedge because the tumor's too large here. And then, of course, if the tumor involves several different lobes, then sometimes you've got to take the whole lung out, and that's called a pneumonectomy. So what about screening? I mean, I see this all the time where a patient will have an abdominal CT scan. They come to the emergency room, they get an abdominal CT scan, and oh, by the way, there's a 6-millimeter nodule in the lungs that was picked up on the abdominal CT scan. Well, that's great. That's the kind of people we want to see when the tumors are small and they haven't spread. So the prognosis of lung cancer is related to the stage, as we just saw in the prior slide, and so therefore you want to discover the lung cancer when it's early. And so some people say, what about screening? How about if we just do a CT scan on everybody? How about if we have all patients who smoke go through the CT scanner and we find them at an early stage, and then we can treat them when there's a chance of cure, and that's being done. Now let me move on here, and there are some bright spots, okay? What I've done is showed you some of the bad things, but there are some good things come along. Something called navigational bronchoscopy. Does everybody have a GPS system in their car or on their phone or something? This is GPS for the lungs. I'll show you that in a minute. Something called video-assisted thoracic surgery. That means doing surgery at the video games. There's something called SBRT, stereotactic body frame radiotherapy, and finally radiofrequency ablation. All these things are coming down the pike. These are things that you're going to be hearing about in the next couple years. So here's the problem. Once you've identified a spot in the lung, what do you do now? How do you make that diagnosis? How are you going to figure this out, what it is? So just as an illustration, as a cartoon, here's a tumor up here in the lung, or maybe it's down here in the lung. And again, these are the kinds of people we want to see. We want to see them when they have this, not when they have that first slide that I showed you that had that big bulky tumor with all those lymph nodes involved. We don't want to see that. We want to see this. But you know, this is the bronchoscope going down the windpipe. And the bronchoscope is about as big as my little finger. And it doesn't go down too far and then it gets stuck. It can't go any further. So it can basically look into the lungs, you know, somewhere around like this area. So if you have a tumor in the main bronchial tubes, that would be accessible by this bronchoscopy. But if you don't, if your tumor's way out here or way out here, sometimes you don't know what it is. You know, you're not sure what it's going to be. So this thing called navigational bronchoscopy uses a standard CT scan and this GPS system, and it guides and steers a catheter into those remote areas of the lungs to get a biopsy, so you know what it is and you know how to treat it. It's less invasive than surgery, obviously, to just go in there and remove it. It's less expensive. And what's important is that it may allow for us making these diagnoses earlier whenever it's still curable. So here's what this bronchoscope actually does. So this is called ENB. You put the bronchoscope down, and it can either go down the right or down the left. And then you put this little tiny thing, and the machine tells you, okay, make a right, make a left, go up, go down, now make a right, no, pull, but no, rerouting, no. Go this way. And eventually, you're going to get to the tumor with this little tiny blue thing. Now again, this is a cartoon, but I'm going to show you what it looks like. Here are the GPS systems actually on it. So here's these electrodes. They go to this machine. The machine, the bronchoscope, which is this thing right here, has a little metallic piece on it, which by computers can tell you exactly where it's located in the lung and can tell you how to get there. Okay, well, what about something else? I mean, these are some of the newer things coming down the road, something called VATS, video-assisted thoracoscopic surgery. And the reason why this came about is because, you know, now we have these great optical systems and high-definition cameras. Now you can see things great when you look through those cameras. And this experience has come about from people who had their gallbladders taken out. Now you come in, you know, you get these little tiny incisions, get your gallbladder taken out. Oftentimes you go home the same day. But because of that, they've developed these great, you know, fiber optic scopes and high definition cameras, and now they're being used in the lung. And the advantage of these VATS is that sometimes there's a shorter recovery time, sometimes there's less pain. Not everybody's amenable to VATS, but many people are. And, you know, again, people will ask for it, so, you know, you need to be able to offer it. And the reason why this is important, because now we can take out smaller tumors with VATS by using that wedge resection where I showed you. You just go in there and take a little piece of the lung. Well, you can do that if you find the tumor early, but if you find it late, then you got to take out bigger chunks of the lung, even the whole lung itself. So with this VATS and with the navigational bronchoscopy and with the screening studies, we are going to begin to find more and more lung cancer. So I suspect that the incidence of lung cancer is actually going to go up. Not because more people are going to start smoking, but because we're just going to find it, whereas we haven't been able to find it up until now. And again, like I said, we can routinely do wedge resections or lobectomies. Okay, SBRT and then RFA and we're done. SBRT really is called hypofractionated stereotactic body frame radiotherapy. That's way too much to say, so we say SBRT for short. SBRT is similar to that navigational bronchoscopy where it uses GPS too, but this is radiation therapy with GPS. And so what you used to do in the old days, you used to get radiation therapy 5 days a week for 6 weeks for about 30 treatments, sometimes 35 treatments. Now you get 3. So you go from getting 30 to 35 to getting 3, maybe 5, depending upon where the tumor is. And basically what this does is it uses some high-speed computers, and it actually tracks the tumor inside your chest. And the machine, I'm going to show you a picture of this, it moves all around, and it fires little tiny X-ray beams at the tumor as you breathe. Because when you breathe, the tumor moves up and down with your lungs. So you're laying there on the table getting your radiation therapy, and the tumor's moving. But now they have these computer systems that can track the tumor in space. And they can say, oh, he's taking a breath, the tumor's moving up, I got to move the X-ray machine to target the tumor. And this minimizes the chance that you'll miss the tumor. Because if you shine the x-ray beam on the patient and the patient takes a deep breath and the tumor moves up or down and moves outside of the x-ray beam, you'll miss it. You miss it completely. So the tumor didn't get any radiation. But this way you never, never, ever miss it because you have GPS there. And some people say that it might be even as good as surgery. So radio frequency ablation, RFA. This technique uses some multi-pronged needle which passes energy into the lung. And what happens is this needle, which you put in and then it has all these different tines. For those fishermen in the room, it's like a treble hook, or it's actually got six little hooks on it. You put that into the lung and then you pass energy through it and it heats up those little hooks. And those little hooks then cook the tumor to such a high temperature that they just die. They just evaporate. So it leaves behind a little hole in the lung. So when you take the thing out, now where the tumor was, you have a hole there, and the surrounding lung just compresses that little hole, and the tumor's gone. And some people are now using cryotherapy, but most people use RFA, use heat with it. And again, this is done usually under general anesthesia. You do it in the CT scanner because you got to put the probe just right. It takes about an hour, and that's all you get. So you come in, you have your tumor treated, 1 hour, you're done. No surgery, no radiation, no chemotherapy, no nothing. Just like getting a CT scan. And so if the tumor were to come back, you can repeat it, you can do it again. The problem is that right now, with these different techniques, it's probably not quite as good as surgery or radiation or SBRT. But now again, there's trials that are being done, and we're part of those, looking at seeing whether or not this technique might be as good as surgery. All right, well, what about prevention? We talked a lot about treatment and all that stuff. Well, I only have one slide to say because there's really nothing that works. Nothing has been shown to convincingly and consistently prevent lung cancer. There's many, many trials, many, many different studies out there, and really nothing seems to work. You know, exercise, you know, that says it lowers the risk of many different cancers, but the data is really kind of weak. Likewise, you know, if you eat a diet that's high in fruits and vegetables, maybe, maybe not. But one thing that is certain is that beta-carotene has been shown to actually increase the risk of lung cancer. So if you're a smoker, you stay away from beta-carotene because that can actually increase the risk.